Hello, and welcome to MetaCell's webinar, New Perspectives on Patient Data, Shaping the Future of Mental Health. Thank you so much for joining us for this hour. We have three excellent expert panelists that will be joining us today. My name is Stephen Larson. I'm the CEO of MetaCell. And before we get started, I just want to tell you a little bit about our organization and why this topic is so meaningful to us. So MetaCell acts as an innovation partner alongside the research and development process of many different kinds of organizations. We mainly focus on helping organizations to aggregate, visualize, extract novel insights from data. We have been an expert in the space of neuroscience for the last 9 years, but that gives us the ability to branch out to many different areas of the life sciences as well from here. And so we've been doing that. Over our last 9 years, we've had the honor of working with really excellent organizations from industry and the pharma space in particular, but also in the hardware space. We've been able to work with excellent foundations and institutes and many universities in the US and Europe and abroad as well. And that's been a great diversity. I think the thing that makes all these unified is the focus on doing great things with data, creating great collaborative interfaces that move research forward in the space of neuroscience and life sciences. We get involved in projects ranging from consultation, building apps, doing market research, collecting data for organizations, actually doing analysis and a lot of work in simulations and building data portals and portals for collaborative engagement. So our webinar today, I'm going to have each of the panelists introduce themselves more fully in a moment, but we will be speaking with Joyonna Gamble-George, who, among other things, is a Science and Technology Policy Fellow with the AAAS. Sean Hill is a Senior Scientist at CAMH, and Peter Selby is a Senior Medical Consultant also with CAMH. So let me just start off by shaping the conversation before I hand it over to Sean. So on our side, we have been seeing many different projects that touch this area of patient data. And we've been working in collaboration with a university in particular. I wanted to show this example, which is early design for a mobile application that I think starts to capture some of the concepts of what we're really starting to see, which is this very personalized way to give the user an experience that adds value to them. So, as we walk around the world, we want to know more about what affects us in our daily lives. Those of us who wear smartwatches already, this is very familiar to you. And so the question I think here is, where do we go now from here? And applications like this that we're starting to look at integrate this information together in a much more detailed way than you've seen before. Things like Apple Health start to go down this path, but of course that's on a single ecosystem, and that's not as personalized or specific to, say, an organization's goals or an institution's goals or a company's goals. So we have started to envision apps that pull this information together from a wide variety of devices, wearable devices, that make the data then available for machine learning, which again needs to add value to the user, not just the organization, but then which also allows for research studies to be undertaken that, through using informed consent, a really important key part, that are very clear, make it very obvious to the end user exactly how the data are going to get used, what's the value, what's the research value of that data. Things like this, I think we can start to create an experience where we really start to move the needle on improving the ability to do research using this data in a way that's fair, in a way that has transparency, keeping equity in mind, but that's also something that creates a great experience, end to end for all the users involved. And in our time working together with organizations, we've really seen a lot of these different kinds of wearable sensors and devices. so we've, I just assembled a short list of different kinds of sensors that we've been involved with ourselves in extracting data from in the past, and the list is long. This list bridges cameras, it bridges, so some things you might not always consider, wearables, but they're, now included in the sets of devices that are relevant to us because they all potentially bear on a research study. They all potentially can collect data that's important for research. It's important for improving patient care and health. So things from sensors that are really high tech that gather a very high resolution motion, sensors that give you the ability to record audio. Even something like an iPhone or an iPad itself can be a sensor like this. A GoPro camera can be an important device for things like this, and things which measure your sleep cycles, things that measure a Wacom digital pen for capturing handwriting. There's been studies where people see changes in handwriting quality depending on their state of a disease progression potentially may decline in that situation. So there's a lot out here, and this is of course not even an exhaustive, comprehensive list. This is just several dozen of the devices that we have seen ourselves that are relevant. And every one of these devices, outputs data in a digital form, and that digital data now is available for machine learning, additional analysis, additional insights that we might gather. But the challenge, of course, is what machine learning to apply, how to do it in a way that respects the privacy of everybody involved, and what insights really should we be trying to gather from this. So that's just to whet your appetite, just a couple of minutes. So now I'm going to go ahead and turn it over to Sean Hill, Senior Scientist at CAMH, and please do introduce yourself a bit more, and and just let me know when you want me to advance the slides for you, Sean.
Great, thank you. It's a real pleasure to join this group, to be on with Joyonna and Peter. And I wanted to just quickly introduce the Krembel Center for Neuroinformatics. I'm actually the inaugural director of this center. I've got a background in computational neuroscience and neuroinformatics. But we inaugurated this center a little over a year ago. And the challenge that we're tackling is, how do you actually first acquire and organize and integrate data about each individual patient in order to better inform care, but also to answer research questions that can ultimately be integrated into care. So, but basically it's all around learning how to acquire and organize appropriate data, multi-scale data, including clinical, behavioral data, genetics, imaging, and mobile, proper infrastructure to organize that so that it can serve machine learning pipelines, for example, and make classifications and predictions. And as well, at the same time, we've got a team focused on multi-scale brain modeling, which is really, it's also machine learning to a large extent, but it's very domain specific. So it's looking at how do we bridge the scales of the brain, from the genomics to the cells, to the circuits, to the whole brain, and to behavior and population aspects, so that we can really try to build a more integrated understanding and identify what is the most useful data that we can measure today that would be the most informative in the clinic. We're doing all of this work in an open science, collaborative environment. That's really the only way that we see that we can achieve the kind of integration and adaptiveness that we need to tackle this challenge. We also fundamentally have to keep training new young scientists to be able to kind of think cross boundaries, to think about the data, think about the neuroscience, think about the clinical challenges, and put all of that together, really training the next generation of scientists. And to accelerate the translation of technologies and techniques developed in the center, we really have a mandate to look at how do we spin these things off, how do we accelerate their commercialization to scale up and to be able to have a larger impact in the clinic. Next slide. And so as I kind of hinted at, I mean, this fundamentally is an iterative process, right? And it's not that we're going to sit down one day and we're going to suddenly know how to do this. This requires collaboration, close collaboration with the clinicians, close collaboration with researchers, the technology developers and providers, as well as then the modeling, machine learning, and so on. And all of this with a focus on the individual citizen, the individual patient, so we can build the best picture possible to inform care for that individual. Next slide. Yeah, and just briefly, that our goal, of course, this is a long-term goal, is really to build a multi-scale perspective on neuropsychiatric disorders, and I would say also across brain disorders, really linking the levels of the brain from the genomics to the cells, to the circuits, to the whole individual. And you'll see that on the next slide that the team of principal investigators that we have at the center really reflects that. So we've got, if the slide will advance, we've got a team on computational genomics led by Srijoy Tripathi, brain circuit modeling by Itai Hai, whole brain modeling by John Griffiths, cognitive network modeling with Andrea Diaconescu, integrative neuroanatomy with Leon French, and whole person modeling with Daniel Felsky. So you can see these teams are really working across the levels, and their mandate is really to collaborate both internally, but also with the clinic and worldwide in order to build the best picture possible, an integrated picture of brain disorders. Next slide. And so just quickly, I wanted to mention the Brain Health Data Bank. This is something actually that we're collaborating quite a bit with Peter Selby and with MetaCell on, but this is led by Joyonna Yu, who's a senior project manager. And it's really an effort to establish a sustainable way of accumulating high quality longitudinal data from the clinical care pathways, of course, with the consent of the patients, use that data to provide decision support for clinicians, and be able to layer in these wearables, these research measures or biomarker measures, so that we can find out, so that we can learn what would be the value to care of using a mobile app or an actigraphy device on the wrist or portable EEG. There's so much technology available, but we fundamentally have to learn and validate how these technologies can usefully inform and reliably inform clinical care. And at the same time that we're doing this, we've engineered this to really accumulate a large amount of data from the various clinical pathways across different data modalities and across disorders, so that we have the best available evidence to accumulate over time that can inform these computational models and machine learning models. So that's my introduction. Thanks for tuning in.
Thank you, Sean, very much. So I'm going to hand it over to Peter Selby as well, introduce himself. I do want to let the audience know, so we see you all assembled there. I'm looking over your names right now. So please do take advantage of the question box that is available to you in the interface. We would love it if you would pose questions as they come up. They're not going to distract from the conversation here, but we would like your thoughts so that when we get to the end of all the presentations, we have a nice list of questions. If there's one that's particularly targeted at somebody's presentation, I will incorporate it as we go. But for right now, let's go ahead and hand it over to Selby.
Thank you very much. So just as you may know, I'm a professor. I'm an addiction medicine physician and a professor in family medicine, psychiatry, and public health at the University of Toronto. And my research program really said, how do we make sure we take what we know and develop what we know that then can be put to the good of the larger population beyond academia, as well as what we, so how do we make sure that that cycle from knowledge generation is aligned with what is needed in society and vice versa? And over the last 15 years, I've worked with using technology and various technological means as a way to bridge that gap. And I'll speak a little bit about that in the next little while. Because wearables, the way I look at it, is just another piece of technology and a way to get data in a more consistent and potentially objective way. But I'll say potentially objective way because there are so many other determinants here, and I don't want to, you know, I won't get into what probably what Joyonna is going to talk about, but hopefully we could get into the discussion. Is that in the rush to respond to providing care through this lockdown pandemic, we are inadvertently digitizing the dysfunctional analog world, and we need to do something better than what was, and use this as an opportunity to do better as opposed to just do the same but make it virtual. Next slide. And so as we are looking at it, one of the things that I've done, and I had to pick something that would, you know, with all the stigma that exists around mental health and addictions broadly, and having treated people with every co-occurring condition you can think of, but knowing that most people with mental health and addictions actually don't come into the specialized system, but actually are seen in primary and community care systems, we need to make sure that those systems are enabled. So we really looked at the journey pathway of this river of care, and there are key guideposts that we need to think about as we are digitizing and collecting data. One is obviously being able to correctly identify and create profiles of patients who are most likely to benefit from what is available, and also to better understand who's likely not to benefit from what is available and might need some adaptations. And why do you need to do this is because as we are able to stream people into better care pathways through the information they provide both passively and actively, then what happens is you're better able to create precision interventions for people. And those precision interventions basically should be able to empower the person to be in charge of their own information that they share with us, but also to be guided by expert algorithms. And the practitioner is also guided by them as they go through this journey. Of course, the practitioners also need to treat, but given the amount of knowledge and information coming at a practitioner is out of date as soon as they finish their professional training. So any data that's coming, and it has to come in a way that it's expert, it's curated, it's reliable, and makes the practitioner's job easier, reduces the cognitive load on them, so that in that 10 minutes or 15-minute appointment with the patient, all they can actually make correct co-developed decisions with the patient. And so we've in this pathway, we've developed ways in which those patients and providers can be supported. And of course, the information and the treatment is enabled through monitoring and automated reminders, etc. Now, these expert systems is what it relies on, but it should be in the background. The process of care should be client-centered, patient-centered, compassionate. We need empathy as well, so that it works. But at the back end is the data that is pooled, analyzed, and automated so that people can make just-in-time decisions, and this can be repeated and aggregated. So this learning health system starts getting developed based on these data coming in. So it's not a static system, a one-way entry point. It needs to be enabled to be a complete loop. And so really taking systems level thinking into the care system. But there is a human aspect to these data. Next slide, please. Because when you look at how data systems have been, how data has been, and how healthcare has been organized, it is siloed off from some of the things that are the major determinants of health. Most people's healthcare outcome is not determined by the healthcare they receive, but is determined by what you see on the left-hand side, which is the social determinants of health, the social community services, the access to primary care, access to a family physician, access to social supports. And so they're in their community, we are here in academia. We need to be able to bridge that knowledge gap and the care gap that exists. And so we've just finished a randomized pilot control trial with 60 individuals recovering from first episode psychosis, to look at what a virtual care manager can do to connect all the dots and be a coach and a guide for that person. And at the same time, in the back end, there's data and analytics happening. Now, we didn't get to wearables here, but we are a bit cautious about getting into wearables right now because I want to make sure that the practitioner and the person needs to be able to analyze and use that information in a meaningful way so that they don't get overburdened by it. So looking at that harmony between research and clinical needs and human needs is a critical way as we go forward, especially as we're thinking about artificial intelligence. We can do a lot. I've been working a little bit with my colleagues with GPT-3, and it's amazing what you can get with NLP. But on the other hand, you do need humans and expertise to interpret it. So as we're doing this work, in the back end, there's data, but I think you're going to need the people in this team, the care manager, the experts that I'm showing here, to be able to make sense of what's coming out there. And I'll just end with saying, it's an exciting time forward. It's really great to work with the Neuroinformatics Center here, and I'm really looking forward to how we can use technology for good, but keeping them in mind that we have to pay attention to things like equity and other factors. So thank you.
Thank you so much, Peter. And to the audience, already the questions are starting to roll in from some of you. Thank you so much. If you haven't taken the opportunity yet, please feel free to also put in your questions. There's some good ones. I'm going to be saving them up here for the end. Yes, please feel free to plug them in. Okay, so now I'd like to hand it over to Joyonna Gamble-George to speak to us about a specific research study that she got engaged in, because I think this will be a nice case study for us to think about some of these bigger picture ideas and focus on.
Hi, everybody. So I am a neuroscientist by training, and a lot of research that I conducted in the past focused on finding potential drug therapies to treat anxiety and depression, as well as Alzheimer's disease. And I did a little bit of research in drug addiction, as well as HIV infection. I'm also an expert science advisor through AAAS Science and Tech Policy Fellowship at NIH, where I just provide my expertise as a scientist to other scientists that are performing clinical trials in patients that are positive for HIV, but they also have co-occurring chronic heart and lung disease, as well as mental concerns. So I'm just going to go over a case study from a research project I did in the past. So here's a study I co-authored with other scientists that are from several institutions within the US, United Kingdom, and New Zealand. And in the study, we wanted to figure out how anandamide, or AEA, in the brain can modulate fear and how an individual responds to stress or perceived threat. Anandamide, if you're not familiar with the term, is a neurotransmitter that is broken down in the brain by an enzyme known as FAAH, or fatty acidamide hydrolase, and it targets or binds to cannabinoid receptors. So usually when an individual is exposed to some stressor that brings about fear, the enzyme FAAH will degrade anandamide, and that'll increase excitability of neurons in the brain region called the amygdala. And the amygdala is responsible for processing an individual's emotions, including detecting threat and initiating fear-related behaviors in response to threat or things we may perceive in our environment as dangerous. So in this figure, we asked the scientific question of whether or not people that have a genetic variant of the FAAH gene that codes for the enzyme FAAH affects their fear when exposed to threatening stimuli. And the threatening stimuli were pictures of faces expressing anger or fear that the study participants had to match to a target face with a similar facial expression of anger or fear. So during the brain imaging experiments, we found in the first panel that people, regardless of how many copies of the FAAH gene variant they have when shown these threatening faces, initially reacted to them as shown by increased activity in the amygdala, which is shaded in blue in the brain image on the right, but these reactions diminished over time after repetition, or when people began to habituate to the threatening faces as shown in the brain image on the left. However, as in the next panel, people that carry 1 or 2 copies of the FAAH gene variant, which expresses less FAAH in cells, so those people with the AA or AC genotype habituated more to the threatening faces than those without the FAAH polymorphism or the CC genotype. So in the bottom 2 panels, which is on the next slide, so the study subjects were given personality tests to determine if there was a link between how people react to stress and the fall gene variant. And the bottom left panel just illustrates the types of responses people give if they recover from trauma and possibly will not develop a fear-related anxiety disorder. And the bottom right panel just illustrates that people with 2 copies of this fall gene variant after taking a personality test reacted to stress at a lower level when compared to the other 2 genotypes. So these individuals will most likely not develop a fear-related anxiety disorder when exposed to trauma or something in their environment that brings about fear. Human studies, just to get into like potential data improvement just from the study I did, human studies that involve brain imaging are quite time consuming and costly when it comes to data collection and processing of that data for accurate interpretation or making sense of the data. So to improve data collection and processing procedures, wearable technology can be developed that can possibly detect changes in brain activity, similar to that of functioning magnetic resonance imaging as used in this study. Also, we can use machine learning based techniques could have been applied to increase the efficiency of finding trends or differences in the data collected on the study participants, or you can use cloud computing that could possibly help with expanding the study to multiple sites in order to increase the diversity of the study population, who mostly in this case self-identified as Caucasian, and maybe expand it to over different geographical areas instead of just one, as in this case was New Zealand. Which will also help with promoting more exchange of scientific ideas and theories and collaborations among scientists. Moreover, with these suggestions, could have assisted even with including data that may help with comprehending fear in the context of other health concerns. So just think about people that suffer from heart disease. Managing anxiety can have an impact on heart disease as well as heart attack recovery. Fear-related anxiety may increase risk factors for heart disorders, such as having a rapid heart rate, which in serious cases can interfere with normal heart function and increase the risk of sudden cardiac arrest. So these are just some ways in which data was collected in the study and processed, such that it can possibly improve with, especially with different types of technological advances.
Thank you very much. All right, so just to kind of bring us into the question answering period, I just kind of want to recap a little bit from my perspective here, what we've just seen. So Sean came in and through an introduction of the Krembel Center for Neuroinformatics, talked about kind of the enterprise of incorporating what clinicians do with what researchers do with analysis and multi-scale data. Peter brought this down to the level of understanding the process by which care gets administered to individual patients and the ways that the technology needs to support what's there and augment what's there. And we wrapped up with Joyonna, who brought us down to a single study and walked us through an example where neuroimaging is used and gave us the opportunity to think about what might happen if we take a single study that is relevant to understanding a condition that bears on anxiety and depression, which is really a challenge for human society right now, and helped us to think about what might be some specific ways to improve that one study. So we kind of have the breadth and we have the depth in this discussion of patient data, how it might affect the future of mental health. So now I want to turn to some questions and have panelists respond to them. And we've got some really good ones. Thank you, audience. Our audience is pretty sharp here, I think we'll see from these questions. So let me start off with one question from William Lillydahl, who says, it is well documented that heart rate variability, HRV, correlates inversely with depression, chronic pain, inflammation, etc. A recent study published in JAMA Neurology suggested that HRV decreases before depressive symptoms arise. Has this created interest in HRV biofeedback-assisted relaxation training to detect and prevent impending depression? Whoever wants to take that.
Okay. Well, I'll go first.
Go.
I talked a little bit about heart rate and the connection between heart rate and anxiety. I'm not familiar with any current studies that are doing that, but I do think there is an interest, since there is a correlation between whether heart rate is increased or decreased and the risk that it leads to somebody having a heart attack, and how that down the line can lead to anxiety. It can lead to anxiety because, you know, the fact that a heart attack can lead to down the line death. I think it induces fear in people down the line that, you know, their health condition is deteriorating, especially if they think that they can't do anything in their current power to actually improve that. So it is important to definitely, I guess, for scientists who are currently maybe studying it or potentially want to study it, to definitely get training in that field, because it definitely can potentially help a lot of people. Because there's about, I think, over 600,000 people that are at risk of having a heart attack. So this really could make a huge impact. And then when it comes to chronic disease, especially heart disease, it doesn't just affect people in the United States, it affects people across the world. So yes, I do believe that there should be increased training, and there should be, there probably is an interest. I know from my perspective, yeah, I would definitely be interested in that type of research.
I guess you know, the way I look at it is yes, we can provide data, but it's the quid term, the so what and what's next. So I give you all this data. Does it actually motivate you to actually take action, or do you start blocking it out? Because we've seen this in other conditions like diabetes, where people actually don't want to necessarily know that there's a group who wants to know their blood sugar all the time, and there's a group who just says, you know, I don't need to know it. And so the question I really think we have to grapple with is, how do we make this, whatever data, whatever information we're getting, whatever variabilities we're getting, actually can help people to motivate change, and also they should have the ability to do something about it. You know, I'm thinking about our patients who have cognitive deficits, and we are trying to get them to focus. Where's the time or the bandwidth for them? So it's not to say we shouldn't do it, but we also need to know for whom this is going to work, under what conditions as well, because that's a critical piece for scale up or making these things universally accessible and available. And that's why should we care about that? Because if you are wanting to get into the work of artificial intelligence and big data, you want to sample across a variety of people, not just a small subset who have the capacity and the advantage to be able to participate. So I mean, that's why I'm really thinking about this from that end as well. Not, yes, it's a great idea, but I think what we need to bring to bear is this broader perspective as we are doing this work.
Yeah, so I'll just add, I mean, you know, in the context of the Brain Health Data Bank, we are working with clinicians in major depressive disorder, and there has been some discussion about the importance of HRV and the opportunity to measure it. So I think there's clearly the interest, there's clearly the recognition that this is correlated, and then the question is okay, so how do we, just as Peter is saying, how do we equitably get that measured? So we need to deploy devices, essentially. We need to get them out there. We need to be sure that that's a reliable measurement. We need to be sure that there's compliance with that, so that that's actually giving us the right information. And then we need to layer that into the context of the rest of the picture of the individual. And so it's not the first thing that we're starting with, but I think it will be one of the upcoming ones that we will certainly, especially in the context of measuring, for example, sleep, we're going to be getting the heart rate to some degree as well, and we'll have to see if we can actually reliably compute HRV from that device.
So next question is for Sean, and turning a little bit to the machine learning and AI side. So Matt Altman asks, Sean specifically, why do you worry about reliability up front? Would it be possible to run different simulations to let machine learning or artificial intelligence help with the reliability decision making?
Well, certainly, but as we know, one of the big challenges is what's the machine learning going to be built from, right? And you're going to build it from data. And when we're talking about wanting to make individual level predictions and where the individual is so unique, we want to be able to ensure that we have good data that represents those individuals. And when you start to aggregate and build just these kind of average models that predict what a large population does without taking into account individual differences, I think you're really blurring the picture. You're not necessarily making something as tailored or personalized as we hear is necessary from the clinicians. So that's where our big focus has been. How do we work very closely with the clinicians to build up the most accurate individual picture possible and use that to be informing the machine learning models? And then, of course, I think there's the opportunity to scale that up and to understand, yes, even in those measurements, there's noise, there's issues, and so on. But we still need to fundamentally address that data quality from the start.
Let's keep going. So Mahan Salehi asks, considering that there are so many health apps wearables that already exist, what are the biggest barriers and potential solutions to integrating them into a physician's workflow and in convincing healthcare adoption?
I'll let somebody else take this to start.
So I guess like one of the barriers with integration of wearable technology, because there is a huge saturation of them right now, with electronic health records, such that they can monitor an individual's health status in real time, while simultaneously making predictions or interpreting the data that is collected about a person's health condition in order to alert that individual to a potential medical emergency or maybe some abnormal health condition or occurrence that occurs in the patient. I think the thing is making sure that when you're trying to do this, that is very accurate and reliable. That can be an issue. But you want to make sure that the sensors have the ability to make accurate detection, but also there's accuracy and reliability in just what is being collected, so you can have proper interpretation when it comes to a particular health condition for the patients. So I think that's, if you can get over that barrier, then the next barrier is, okay, how do we integrate the two together? How do we make sure that, the providers do not feel like, because think about it, they're already burdened with a lot of work with the patients that they're seeing. So how do we make it so it's like an integration into their normal process, and it doesn't feel like it's extra work for them? You don't want to overburden the system. So really you have to be probably, I guess if you have these wearable technology, do a lot of testing where you do like user testing or user experience to see if they play with the technology that you're developing, that they actually see some use to it, in order to create like this buy-in with the medical profession that, okay, this really does help me with my workflow, it makes it more efficient. It also helps my, patient with, helping them improve this particular health condition. So I think that's at least one barrier and also one solution to how to go about it.
Yeah, I fully agree with you, Joyonna. We've got a deployed solution out in about 300 plus clinics right now in Ontario, and with about 1,000 plus practitioners. And we don't pay them to adopt it, but they use it because it creates utility and function for their work. So I think anybody who's designing an app or wearable, and we've seen that there's been with every new technology, there's a rapid adoption, and it doesn't, and then it falls off. And I think it's because people have not looked at what is the value chain and what are all the drivers that'll keep it going. So there's a lot of noise, and that's fine. I think any new innovation, there needs to be a lot. I mean, if we take a look at cars, there were lots of manufacturers of cars, and now we've got pretty much, it down to a few, and there'll be further consolidation over time, I'm sure. So first of all, design with I work a lot with primary care providers, right? And if you think about a family physician, you've got 10 or 15 minutes going to be able to see a patient, and you have to make a mind switch every 10 to 15 minutes to a new problem. So that really creates a problem for them. And I speak to my colleagues who their patient comes in with reams of data from their wearable that tells them their heart rate and every little blip. So there's too much noise, and what has happened is that practitioners are getting, they're saying, look, I can't pay attention to this because you've come for 10 minutes. We need to talk about this, not these reams of paper. So we're trying to think about how do you make it easier rather than harder for the practitioner. And I think that needs to be part of the design of any new technology, is where does it fit into the workflow? Is it it's innovation if it's improving the efficiency by 50%? If it's not meeting that, let's not bring it out to the market, because it's just going to create more worries for people unnecessarily and drive unnecessary visits into the health system.
So I'll just add to that. I mean, I think this value chain is very key, and part of this is understanding very clearly how does your app or how does your wearable, what does it actually measure? What is it actually informing you about? How does that relate to something specific in your decision process, for example? I think otherwise it's research. We've spoken to a lot of companies that basically have developed things that are great potential ideas, really cool technologies, but fundamentally they're looking for patient populations that they can test them on, build up, get enough data, get enough evidence to prove that it is actually consistent, reliable, measuring what you think it's measuring, and informative. And so because in that value chain that Peter's talking about, to actually be able to deploy some new app or some new device as a standard part of care, right, is a really non-trivial thing. You've got to really think about the whole process and what is the value of actually making that investment into the process, and be able to have confidence in that.
Absolutely. And if I may use my host prerogative also, just to mention as well, since I'd be remiss in mentioning, it's kind of on theme for us. We do think that the actual way that software stitches the data together is very critical, and it doesn't need to be large-scale software development, but through good use of interface design, through good use of data management, simple things like the way the data stream, the kinds of analysis or graphs you put together, very, very simple things. It can make a very large difference in the experience of actually using data, taking advantage of it. And I think because it becomes an interdisciplinary project to bring good software teams together alongside all the other stakeholders that need to be brought together. It's challenging because there's very few individuals that get to see the whole picture, from the concerns that we're talking about here to getting in the guts of the latest operating system on your Apple device or your latest Android operating system, and how to make sure that the way that these data are coming together are the most efficient, or how do you interface with that EMR that as Joyonna was mentioning before, right? How can you keep in mind the different user types that are going to be involved, so that you make sure that when they're looking at the data, they're actually getting what's relevant to them. So all these kind of questions of design kind of fit in the gaps, I think, between a lot of these considerations. And I don't know, we just see that a lot. So I thought I'd throw that perspective in there, that it's an important glue. So let's turn to another question that has come through. And by the way, thank you everybody for submitting questions. Please continue as we're talking. We're going to have a few more. So this one's for Dr. Selby in particular, from Nadine Akbar. Nadine asks, can you go over research methods you use to evaluate programs? And I believe Nadine's getting at evaluating sort of virtual care managers. How would you evaluate, I guess, whether they're good or bad? And Nadine suggests, for example, qualitative or mixed methods or randomized controlled trials, and how do you involve community stakeholders in that evaluation?
We don't hear you.
I'm muted. Sorry about that. Yes, my answer is yes to all. It depends on what you're trying. The method in the design method should depend on what you're trying to achieve, and at different times. Where we have landed with this is doing a lot of qualitative work before. So, for example, we were introduced an app into our clinic based and virtualizing our clinic process. We spent a lot of time with our end users to figure out right from their digital literacy all the way to device to how they would actually even download an app. Do they even know what an app is? And figured out that this helped us sort of co-create what it is. And then, of course, you can do a sequential mixed method where you do a lot of code development initially, then you have interpretation by the providers and users and yourself, and then you can take it to testing. And then be really clear, what is the active ingredient you're trying to test? When you look at mHealth and all these other, it's really hard to pinpoint what exactly is the active ingredient or active ingredients. So I think that's where you do need the randomized control trials, and you vary what you're trying to answer. And it depends on your motive for a randomized control trial. Is it to get published, or is it actually to understand the process, or both? And then you have to have end users involved, not only. So for example, in our virtual care teams of technology-enabled collaborative care, we actually have a peer worker, not only as part of the research team, but they're part of the care team as well. Because I think that's how we start to break down the silos between research and care, and keep making sure that there's a bidirectional flow of information. So in fact, we're just publishing a paper written by an end user who participated in our trial, and so that she's writing her perspective into the publication. So I think that's the way we need to go forward when we are bringing technology into the next generation of research, and aligning clinical and research work together.
Excellent. Okay, now since that one was specifically for Peter, here's another one for Sean. So Christoph Diaz asks, can Sean tell us a little more about how CAMH integrates research and their long-term multi-scale modeling efforts with the real-life clinic? Are those programs, research and care, separated or integrated?
Yeah, it's a great question, and it's also a grand challenge, really. So the center is really established to iteratively integrate more and more research into care. And what I really saw as a great opportunity actually is that there is a lot of low-hanging fruit to start looking from the neuroscience perspective, and to start looking from the multi-scale perspective to say, what would be something useful that could be layered into that decision support tool for a clinician? And so, for example, one of the first things that we saw is that if we have a behavior that we know how to relate to principles in the nervous system, such as excitability, which we know is impacted in a lot of different brain disorders, if we start to be able to link behavior to the underlying neuroscience and neurophysiology, and that's something that we can measure and use to inform in the clinic, that's a starting point. It's the first link of getting neuroscience into these clinical pathways. And so, in fact, the clinicians that we talk to, first thing that they're asking for is measures of sleep. How did their patient sleep in the previous week prior to a visit? Because that has such an impact. Now, in the modeling, in the computational modeling across scales, we can start to use measures such as EEG, such as TMS EEG, such as looking at signatures of alterations in brain circuit excitability as a way of starting to understand the link between excitability, sleep deprivation, any kind of sleep disruption, which is essentially common across all brain disorders. So any brain disorder, from neurology to psychiatry to addictions, is associated with disruptions in sleep. So this gives us already something as an anchoring point if we can measure this with a wearable, we can look at disruptions in sleep, we can start to build a relationship and start to deepen the computational models that help us understand the links between the genes, between the immune responses, between the cellular physiology and so on, to start to build a picture into the clinical care pathway. So I would just say it's starting. We're going for the low-hanging fruit first, but we want to iteratively keep building upon this to get more and more of the mechanisms relevant to clinical care.
Great. And another question for Joyonna. When it comes to human brain imaging, which you showed in your study, it's been used for a while. What do you think are the exciting new applications of brain imaging, and how might it be combined with other data types, data sources to advance our understanding of mental health?
So I think Sean touched on this a little bit. So I know scientists are combining different imaging techniques together to understand how the brain works under normal conditions and during times of disease or in disorders from a structural, functional, molecular perspective, and even from a perspective of understanding like electrical activities of neurons. So for example, fMRI, which are based on like coupling of neurovascular or blood flow activities, are being combined with EEG, which measures brain cells electrical activity. That could be one example. Also, there's image-guided therapies such as brain stimulation techniques. And I think Sean mentioned TMS is one that can be used to modulate activity in specific regions of the brain by changing the electrical activity in the brain. And this type of technology may be beneficial to people with neurological conditions such as Parkinson's disease or even schizophrenia. Also, there's optical fluorescent imaging that's being used to help identify visually brain structures involved in disease, such as brain cancer or neurodegenerative disorders. When you want to combine imaging with machine learning, you could possibly do it to help classify and predict likely treatment outcomes of a major anxiety and depressive disorder, which is similar to what the research I've done in the past. Or you might want to use it as a tool to just try to investigate more the genetic basis of these mood disorders.
If I could just add to that, I mean, what I'm here, I mean, obviously my colleagues follow from both research and clinical. You know, one of the big fields of mental health is we still don't actually have a objective individual diagnostic measure. And so, yes, these are all predictions and these are probabilities and they're group differences, but for that individual patient, you know, this is one of the challenges in translation of science. We work in probabilities and odds versus when you're dealing with people at a clinical level, they want certainty with what you're doing. And so, you know, so I think the work still needs to be done is, can we actually come up with individually diagnostic tests that tell people, yes, you actually rule in the diagnosis, you rule out the diagnosis, and then you can predict prognosis based on a combination. And to me, that's the most exciting part of this, is that's where we need to be able to go to say, yes, this person has this condition. It doesn't matter what label you're putting on it, but it's this condition we're dealing with. And that's the holy grail, I feel. We need to go there.
We'll close off with one more, and this one's for Sean, and then I think we'll be at the top of the hour, everybody. So this one, second one from Mahan Salehi asked to Sean, you've mentioned you've seen a lot of new cool tech that needs clinical testing. Is Krembel Center and CAMH as a whole looking to partner with technology companies or mental health startups to help them co-develop and clinically test, validate their inventions, or is the emphasis to develop solutions internally?
No, so we're a very collaborative center, and we're very much looking to, you know, develop the right model for collaboration with technology partners and startups and so on. You know, of course, there's constraints in how that can be done, but I think that there's a lot of opportunity as well. So we absolutely are, you know, open and interested in discussing those opportunities with technology developers and you know, mental health app developers to see how do you really get a the evidence sufficient to really demonstrate that the app or the technology is doing what is claimed.
Yeah, and we also go the other way. We also have internal inventions that we work with partners to scale up. So, we do have examples like that. And so we are very, very open to having those conversations. There's a large tech transfer office. I mean, there's a tech transfer process as well as a large business development office to take a look at how do we move this forward, because it's not only one organization that's going to help deal with the burden of mental illness and addictions that is affecting society. So, yeah, very open.
Fine. All right. Well, we'll close it off there. Sean, Peter, Joyonna, thank you so much for joining us. Attendees, thank you for spending this hour with us here. This is one in a series of webinars that MetaCell puts on from time to time. So please stay in touch. The recording of this will be available afterwards as well, and there'll be other great webinar content from us coming down the road. But for now, we'll sign off and say thank you to all of you for your participation.
Great. Thank you very much.
Thank you. Nice to meet you, Joyonna.
Great to meet you.
Nice to meet you too.
Yeah. Bye, Steve. Bye.
Thank you all. Bye-bye.